to do is welcome everyone to the Braden Scale for the prediction of pressure ulcer risk. So we've uncovered our technical difficulties, and you should be hearing audio and seeing the video right now. A few bookkeeping items. You can ask questions by typing in on your dashboard on your right-hand side. Know that we're being recorded, and this archived version of this webinar will be made available via email to participants. If you didn't get a copy of the handouts in advance, we sent that to all registered participants. We'll be sending out again at the close of this webinar to everyone registered a copy of this deck, so rest assured you get an opportunity to get handouts. And you also have an opportunity to interact with speakers, as we'll be sharing speaker information at the end of this deck. Now what I'd like to do is introduce us to the speakers who are going to be presenting today's educational opportunity. And first up is Lynn Ferguson, who will be presenting the Braden tool today. And we're so thrilled to have Lynn. Lynn is a CWOCN, so she's a certified wound ostomy continence nurse, and she's also on the WoundRounds clinical team. And Lynn brings a deep background in wound ostomy continence nursing, and in particular in deriving better wound outcomes in the long-term care setting. We're also pleased to have joining us today Ann Schurig, who's actually the Vice President of Clinical Operations from WoundRounds. And Ann is also a CWOCN, and she's had several leadership positions within this professional society. We're very pleased to have her joining us today as well. And lastly, a word about myself. I'm your moderator today. My name is Deborah Kurtz, and I am an experienced person in helping to moderate WoundRounds webinars and bring to the table expertise in WoundRounds clinical marketing. What I'd like to do is quickly go through the objectives that the speakers have for us today, and then I will turn the webinar over to Lynn Ferguson, who will actually deliver the information that we have prepared for you on the Braden tool. So what we're accomplishing today is learning about the Braden tool, why it was developed, and the key benefits that it brings to facilities who use it to predict pressure ulcer risk. And an important part of the Braden is what's known as the subcategories, that they comprise the risk assessment tool, and they're very important in terms of driving interventions. We'll be discussing appropriate interventions for each of these subcategories as well. And really bringing the Braden to life is a discussion of two case studies that will help you understand how the Braden is practically used in organizations to bring forth better wound care. And lastly, we'll wrap up today's 60-minute session with a quick demonstration on a tool to automate the Braden scale in a clinical and at a bedside setting, and that will be performed by Ann Schurig, and she'll actually be demonstrating the WoundRounds tool. So with that, I'd like to officially kick off this webinar today to our speaker, Lynn Ferguson, and Lynn will go over the Braden tool. Take it away, Lynn.
Good afternoon. Thank you, Deb, and thank you for the opportunity to speak with all of you today. Our topic for discussion, as Deb mentioned, is centered around risk assessment in general, but more specifically on the Braden scale for the prediction of pressure ulcer risk. As professionals that are part of today's ever-changing healthcare environment, we are all aware of the emphasis on eliminating facility-acquired pressure ulcers as much as possible. Some of the implications associated with pressure ulcer development include, as you know, expense, pain, social isolation, and perhaps even depression. In addition, pressure ulcers can be stressful, emotionally draining on the family. They can also be time-consuming and emotionally and physically draining for staff members caring with those with pressure ulcers. In fact, in 2006, adult inpatient hospital stays with a pressure ulcer diagnosis totaled $11 billion. When we are looking at how to properly manage pressure ulcers, some of the overall goals to consider are identifying those at risk, preventing additional breakdown, managing complications such as infection, maximize healing potentials, and of course implement interventions that effectively prevent and manage those pressure ulcers. Because of the aforementioned implications of pressure ulcers, i.e. cost, pain, suffering, etc., which we are all familiar with, utilization of a risk assessment scale will not only help us guide us in the identification of who is at risk, but also help in targeting specific areas to focus on, which we call subscales, and we'll talk more about these later. In turn, focusing on these subscales will not only assist in identifying those at risk, but will also help us identify appropriate clinical interventions to prevent pressure ulcers from developing. And the key is implementing those interventions, and we'll talk more about those as well. So what are some of the benefits of risk scales? Scales help us to identify not only the extent to which an individual exhibits a risk factor, in other words, the widely accepted risk scales allow us to assign a quantifiable rating within each subscore. How at risk is the patient when it comes to nutrition, for example? What kind of expectations should we have for risk scales? They must have demonstrated reliability and validity. And in my clinical expertise, I have seen people develop their own risk scales. And what's important to realize is that we need to have scales that have demonstrated reliability and validity. Reliability being the degree to which the results can be replicated, and validity being the accuracy of the actual assessment tool. Included in validity, we'd like to have the two additional components identified, and that would be sensitivity and specificity. Sensitivity correctly identifies those patients who are at risk. Specificity actually identifies those patients who are not at risk. So again, making sure we have demonstrated reliability and validity is key. We need to establish a policy. You know, when you are in your facility and you're implementing a new form, a piece of medical equipment, changing a process, establishing a new policy is put into place, and staff is therefore expected to follow that policy. Similarly, facilities ought to have a structured policy in place for the use of a risk assessment scale based on your specific healthcare setting. These policies should include what areas will be targeted, who will be performing the assessment, and the timing of the assessment and reassessment. Once you determine the risk level, how will it be documented? Will it be on paper? Will it be electronically? The facility needs to be consistent so that everyone's on the same page. How are you going to communicate the risk to the interdisciplinary team, PT, OT, dietary, restorative, so that you're all on the same page and following the individualized care plan for that specific resident? Do you have the ability to create customizable reports and disseminate them to the team as a result? What's important is that we make sure that risk assessment is performed upon entry to our healthcare setting and repeated on a regularly scheduled basis, or when there's any significant change in the individual's condition. More on reassessment further on in the presentation will be covered. Education. It's important to train even when the nurses use the tool regularly and for long periods of time. There was a study done at Detroit Medical Center where they actually showed the accuracy of the Braden scale, and despite the fact that they were all trained initially, only 75% of them correctly rated the Braden scale. So what we usually recommend is that annual competencies for the Braden assessment take place on an annual basis. Further, the definitions for the risk factors and subscales are essential in both paper and electronic documentation systems. While it's important to train the nursing staff, it's also essential that the CNA be an active participant in the training. When we talk about involving the CNA in the training, it's also important to note that only licensed personnel can complete the training. So we want to include the CNAs in the training so that they understand what the tool is, what it offers, how it identifies the subscales in those people that are at risk, but know first and foremost that the CNA should not be completing the Braden risk assessment tool. Let's talk a little bit about documentation. Documentation of the Braden is important so that we can communicate within the multidisciplinary team. It provides evidence that care planning is appropriate. It also serves as a benchmark for determining the individual's progress. How will you capture this information? How will it, again, be disseminated to the appropriate members of your healthcare team within your building? The next slide shows you various risk assessment scales that are available currently. You'll see several for the adult population. You'll also see a derivative of the Braden for the pediatric population, and you'll see several neonatal risk assessment tools as well. With the adult population, the Braden and the Norton have been the most extensively studied in the adult population and have been found valid for the prediction of pressure ulcer risk in a variety of settings. Further studies have demonstrated that the Braden has been tested in the largest number of subjects in the greatest variety of settings and has demonstrated that reliability and validity that we're looking for, which is why we're focusing specifically on the Braden scale today. A little bit more about the Braden. The Braden was developed by Barbara Braden and Nancy Bergstrom. It was first tested for reliability and validity all the way back in 1987. So this scale has been in existence for 25 years. It's important to note that it's not a skin assessment tool, but it is intended to be a supplement to good nursing judgment along with clinically reliable pressure ulcer interventions and continuous quality improvement efforts. This tool is available on all continents and translated into many, many languages. There was a study done in 2006 in which comparison was made between the Braden, the Norton, and the Waterlow scale. And basically it was determined that the Braden was the tool that demonstrated the best reliability and validity once again. Some benefits of the Braden scale: it's widely used. As you can imagine, based on what I've already said, it's been well researched and published. It helps us differentiate between those at risk and those who are not at risk for pressure ulcers. We talked already extensively about reliability and validity, and we talked about the fact that it's available on many continents and into many languages. For those of you who might be interested in obtaining a copy of the Braden scale, we've provided a screenshot of it, and while I realize it might not be easy for you to visualize that on your screen based on the size of the font, the URL is listed there on the left-hand side, and that will take you directly to the Braden scale. There are also other tools available online that you might want to tap into as well. So we talked about the Braden scale in general, but what's important for us to focus on is those 6 subcategories that exist within the Braden, and those are listed on the screen in front of you. Risk assessment is not valid and reliable unless those administering the assessment have access to the complete scale and the subscale descriptors. The subcategories are all rated from 1 to 4, 1 being the most risk to 4 being the least risk except for friction and shear. Friction and shear are rated from 1 to 3, with 3 being no apparent problem, and each includes a brief description of the criteria. So there are definitions that go along with each subcategory. And these subcategories identify which risk factors are present so that the interventions can be implemented to reduce those specific risk factors. And the interventions are a key to getting better outcomes within your building. So we'll talk further about those interventions in a little bit. This slide shows you what the Braden total score looks like. You'll see they are assigned numbers, and we'll show you exactly how that works. On the right-hand side, you'll see the Braden scores with the risk of pressure ulcer development. So as you can see, a higher score with a Braden gives you lower risk, whereas a lower score gives you a higher risk. The Braden is derived from totaling the numerical rankings from each of the subscales. As we talked about, a lower total score indicates a greater risk for development of pressure ulcer. One thing to also keep in mind here is if other major risk factors are present, and you may be asking yourself, what type of risk factors is she talking about? Advanced age, fever, poor dietary intake of protein, diastolic blood pressure less than 60, hemodynamic instability, the resident or patient should be advanced to the next level of risk. And that shows you that information as well, and that is available on Barbara Braden's website as well. And what we need to keep in mind is that a total number is not what we're looking for. Overall scores, we need to help drive the necessary interventions necessary to prevent pressure ulcer development. So those subscores indicate where the challenges exist and help us to provide proper care. The first subscore that we're going to review today is called sensory perception. This refers to the individual's ability to respond meaningfully to pressure-related discomfort. Examples of pressure-related discomfort may include things like feeling discomfort to their tailbone, wrinkled bed linens underneath a patient or resident, ill-fitting shoes, lying on IV tubing or a Foley catheter, for example. Examples of those who cannot adequately communicate their discomfort might include those with confusion, disorientation, oversedation, lack of responsiveness, in acute care setting, patients on a ventilator, even including people who do not speak the native language would be considered people that would be at risk for sensory perception. And here on your screen in front of you, you'll see the definitions for scoring sensory perception. The key to scoring this category is understanding the degree, again, to which a resident or patient can respond to verbal commands, first of all. Secondly, are they able to communicate their level of pain or discomfort to staff? The second subcategory is activity. Is the resident chair-bound, bed-bound? Are they ambulatory? How often? So when we're looking at the activity scoring, the key here is knowing where the resident spends most of his or her time. For those who are ambulatory, the frequency of ambulation helps determine the risk. And again, a lower number is a higher risk. The next subcategory we're going to review is mobility. Mobility refers to the individual's ability to change or control their body position. Are they able to shift their weight independently, or do they rely on staff for those types of things? Incremental shifts in body weight every 15 minutes for those who have the ability to reposition themselves is ideal. Unfortunately, mobility is often confused with activity, and these are not the same. For example, a patient may be able to sit in a chair and have good mobility, but might not be able to shift their weight. So again, this is refers to the ability to change or control their body position. When we're scoring mobility, again, you have a screen in front of you. We consider the frequency with which the patient or resident is able to reposition him or herself and what degree of assistance is required. Now, we talked earlier about interventions, and this is definitely a key to utilizing the Braden Scale is what interventions can we put in place? Some possible options are on the screen before you. However, this is certainly not an all-inclusive list, but these address things like sensory, activity, and mobility. So maximizing remobilization, getting PT/OT involved, putting the patient or resident on a turning schedule. If so, how often? Elevating the heels off the bed. Obviously, we know that heel pressure ulcers are a huge problem in long-term care, and so we want to do whatever we can to alleviate types of pressure ulcers to the heels. Interventions such as not positioning directly on the trochanter or using a 30-degree sideline position, not massaging bony prominences, using pillows, wedges, ought to be considered as well. The fourth Braden subscale addresses moisture. Evidence shows that the greater the exposure to moisture, the greater the effects of pressure and friction and shear have on the skin. So while we are trying to redistribute pressure, we need to keep in mind that friction and shear can have a huge impact on the skin as well as moisture. So what do we need to do? We need to make sure we protect the skin from moisture. What types of moisture exist? Urine and stool is pretty obvious to most of us here on this call. Two other things that might come to mind for anyone who's been involved in wound care. Wound exudate is a very popular problem when it comes to moisture. This is why we don't want to leave saturated dressings in place. If they are soaked and they need to be changed, then that's something that we need to do because macerated skin breaks down quicker. If we have residents or patients that frequently perspire, or have a fever perhaps. Those are issues that contribute to moisture as well. Here we have a couple of examples of skin impacted by moisture. Incontinence-associated dermatitis obviously has had a major impact on this particular person on the left-hand screen, and maceration secondary to wound exudate. As I said earlier, any macerated skin has the potential to break down as well and can cause further issues. So when we're scoring moisture, you'll see your screen in front of you as well. The key consideration is to determine how often the skin is moist and how frequently the linen or clothing should be changed. So when we are repositioning residents or we are transferring residents, we need to be very cognizant of how moist their skin as well as their clothing and linen is. And if those things are moist, we need to take appropriate interventions to make sure that that is changed. So what type of interventions should we consider? Obviously, we want to address the cause. Moisture barrier with each check and change is important. Utilizing products that wick away and hold moisture. For those with frequently loose stools, containment devices can be very helpful. So there are some things there we can consider. The next subscale to be addressed is that of nutrition. Here we take into consideration what the usual food intake pattern is of the specific patient or resident. Noting that also patients that are at risk for pressure ulcers should be placed at a higher risk if their labs are abnormally low. So some examples to consider. A patient that might be NPO after midnight should not be given a low nutrition score if his or her usual food intake is adequate. And that's why we say usual food intake. Conversely, the patient who's in acute care and receiving TPN should not be rated as adequate even though the patient might be malnourished, as evidenced by low prealbumin levels. So when we're considering how to score a resident's nutrition, the total dietary intake is considered. In other words, how much of a complete meal do they usually take in? The delineation here could be considered 1/2 of each meal or more or less. But you should also take into consideration the number of servings of protein that is consumed per day as well. So you'll see that in scoring nutrition, they talk about the amount of food they eat, but also the number of servings of protein. And this is continued on the following slide also. And adequate or excellent includes 4 or more servings of protein a day. So what are some possible nutritional interventions to consider? Something very obvious to all of us would be to get the dietitian involved. Considering, we talked about protein intake, considering calorie intake to spare the protein, supplementing, acting quickly to alleviate any deficits that are noted. Consider supplementation, making sure that the residents or patients have assistance in taking those supplements. And the final subcategory of the Braden scale is actually friction and shear. And a lot of people think friction and shear are the same thing, but in fact they're not. Friction is surface caused by skin rubbing against another surface. Shear, however, and good examples of friction might be an agitated patient rubbing their elbows or heels on the sheets, an orthotic device or a shoe causing trauma during ambulation. We've all had shoes that don't fit us quite right, and this is a good example of friction. When we're taking into consideration shear, a good analogy here would be a patient sliding down in bed after the head of bed has been elevated for a meal. Or another example would be when we drag patients up in bed or allow their buttocks to drag across the surface during a transfer. So all of us clinicians have seen this happen once or twice in our lifetime, I'm guessing. So when we're scoring friction and shear, a brief reminder, this is scored from 1 to 3. And when we're assigning a score to this category, the key point to consider is what extent the resident requires assistance with moving. Is it minimal, moderate, or maximum? without sliding against the sheets or any other types of devices. Also of consideration should be the degree to which the resident maintains good position in bed or chair. Do they slide down? If they do, how often? Do they experience any spasticity, contractures, or agitation? Those are definitely things to consider as well when scoring friction and shear. Some possible interventions to consider: maintaining the head of the bed at an elevation of 30 degrees or less unless contraindicating, utilizing things like trapezes, lift sheets, and draw sheets, protecting elbows and heels if they're being exposed to friction, utilizing the knee gatch on the bed to keep them from sliding down, things of that nature, using any specialized lift sheets or ear transfer devices to help move the patient and prevent any lateral shear might be helpful as well. Some other general care interventions to consider. I know this way back when that in all my care plans in nursing school I added in massage bony prominences. Obviously that's not something that we continue to do anymore. Donut type devices. Non-clinical people often think donuts are very helpful, but we've actually found that they're not. They actually can cause further damage to the skin. Maintaining good hydration. We want our residents well hydrated, and avoid excessive drying of the skin as well. So you may be asking yourself, how often do I want to reassess and complete a Braden on my particular patient or resident population? In actuality, the frequency of ongoing assessments varies by clinical area and the stability or liability of the patient population. So you'll see on your screen in front of you, for the acute care environment, you'll see that the ICUs complete a Braden every shift, and most med-surg areas do so daily. In home health, they're performed with each nursing visit, and in skilled and long-term care environments on admission and weekly and monthly thereafter for long-term care. Some additional risk questions that pertain to those of you who might be involved in the MDS include the following. Does a resident have a previous scar over a bony prominence, and does the resident have a non-removable dressing in place? What I'd like to do at this point is go through a couple of case studies with you so that we can visualize how the Braden would be utilized in this particular situation. In case study number 1, we have a 79-year-old obese woman admitted to long-term care with diagnoses of altered mental status, hypertension, and diabetes. She's alert and oriented ×1, responds to verbal commands, but cannot always verbalize what she needs to staff. She's incontinent of both urine and stool, generally eats more than 50% of each meal, and typically takes her evening snack with prompting. She's chair-bound, but relies heavily on staff for her repositioning needs. And she also frequently slides down in her wheelchair, unfortunately, and her bed. So here we have on our screen an example of the Braden Scale form. Again, that's available on the website. Okay, so we're looking at sensory perception. And here we have, because we mentioned that she was alert and oriented ×1, she responds to verbal commands but cannot always verbalize her needs to staff. So we're going to score her as a 3 there. As far as moisture is concerned, she's incontinent of urine and stool. So we're going to score her as, as a 1 because she's constantly moist. Because she generally eats 50% of each meal and typically takes her evening snack with prompting under the category of nutrition, we're going to score her as a 3. If we go back up to activity, because she's chair-bound, we're going to score her as a 2. And she relies on staff for mobility. So again, we're going to score her as a 2 and very limited. We also made mention earlier of the fact that she slides down in her wheelchair and her bed, and so that's definitely a problem for her in the friction and shear category. And what we'll actually find is that we have a total Braden score of 12, which puts her at high risk. So the question becomes, what exactly do we do about this? So if you can see this, and again this is available on the Braden Scale website as well, you'll have, let's see, what are we? High risk being a 12, and you'll see some possible interventions there that you can choose from to put in place. Things like protecting the heels, managing moisture, nutrition, friction and shear, increasing the frequency of turning and repositioning, etc. So it's important that you make sure that you put the appropriate interventions in place. Case study number 2 is a 69-year-old male admitted to a skilled unit, status post right hip replacement. He's alert and oriented ×3, expresses his needs freely to all healthcare professionals as appropriate. He is currently ambulatory with assistant therapy for only short distances, otherwise he spends his day in the better chair. He does have a trapeze. He is able to reposition himself independently and maintains fairly good position while in better chair. His skin is typically dry. He uses a urinal and bedside commode with assist as needed. He, however, does not care for the food in this particular facility, so he eats less than half his tray, but snacks in between on diet soda and pretzels from the vending machine. Sounds good, right? He also refuses all of his supplements. So once again, we see a paper copy of the Braden Scale in front of us, and this is case study number 2. So we're going to run through this similarly to the previous case study that we did. Sensory perception doesn't appear to be a problem for this gentleman. So we're going to say no impairment. Okay, moisture. Again, he is using the commode in the urinal, so we have rarely moist for him. Activity. He's ambulatory with assist, but only for short distances, so he spends most of his day in the bed or the chair. So that we're going to score him as a 3 for walks occasionally. He does have a trapeze on his bed, and he is able to reposition himself. So we're going to score him as a no limitation for mobility. Here's where it gets tricky, his nutrition. Basically, we're going to give him here a 2 because it's probably inadequate. He eats less than half his meal, he refuses supplements, and he's not doing a great job with what he's choosing as far as protein, etc. Those pretzels and diet soda aren't cutting it these days. And friction and shear doesn't appear to be a problem with him as well, so we're going to give him a 3 there. And then we're going to total up his score, and we're going to give him a 20 on the Braden. However, normally you would not see a 20 being a high risk or a risk category on the Braden if we look at this next screen. However, because of his nutrition, we're going to increase him a level to the at-risk category. So normally you would say at-risk is 15 to 18, but even though he's a 20, we're going to increase his risk, and we're going to need to put those appropriate interventions into place. So things like frequent repositioning, managing moisture, nutrition, pressure reduction, support surface if chair-bound or bed-bound, etc. In summary, what I'd recommend you consider is the following. It's really important to develop and implement a plan for your facility. Not only your facility, but your patients and your residents. From a facility standpoint, you need a policy, folks. You need to know what your policy is. You need to implement it. Your staff needs to be trained on that policy. In addition, staff education is important. An annual competency would be highly recommended, in my opinion. Again, people get used to filling out a piece of paper or documenting, doing something for a period of time. People get careless, etc. Reinforcement is always key. You need to decide how you're going to document the Bradens. Paper, electronic. Can you generate any reports based on the results that you obtain? So your documentation is important from a facility standpoint as well. The other thing that you need to keep in mind is when we're looking at our patients and residents, we obviously need to do this, do the risk assessment, assess the patient, obtain your overall score, and that's very important. But don't forget to choose the appropriate interventions and implement them all. Communicate and disseminate the information so that you have an individualized care plan that all members of the healthcare team are following. Remember, your overall goal is to reduce and eliminate pressure ulcer development, and the Braden tool can help get you there.
Lynn, thank you so much. That was a great explanation of the Braden, and I will probably never look at diet soda and pretzels quite again. But thanks also for those case studies. It really helps to bring this information to a practical light. What I'd like to do right now is take a look at some of the questions that came in while Lynn was presenting this material and tee these questions back up to Lynn. And I wanted to also thank her because she gave us these great references for additional information and also these wound and skincare resources if those of us are interested in getting more information. And you'll get copies of this deck if you haven't already as a pre-registrant. We'll be sending this deck out to everyone again at the end of the webinar. So what I'd like to do right now is open up the floor to questions to Lynn. This is her contact information if you'd like to contact her offline. And what I can see is our first question for Lynn is how to effectively implement the Braden scale cross-functionally across the interdisciplinary teams within a facility. And I'm wondering, Lynn, if you have any tips or advice for us on how to do that. Thanks, Lynn.
Great, Deb. That's an excellent question, actually. What's important to keep in mind when we're instituting the Braden is that we don't want staff to think that this is just going to be another form that they need to fill out. We want to have them embrace the opportunity to utilize this. Education we talked about earlier, in making sure that the staff is educated on why we're doing what we're doing. Getting the support of administration obviously would be key, and making sure that we train people on why we're doing what we're doing. I mentioned earlier that the CNAs are an important piece of this because your CNAs are implementing the interventions oftentimes, so making sure that they understand why everybody's assessing these patients and residents on a regular basis.
Lynn, thanks for that great question. What I'd like to do now is introduce our next speaker, who is Ann Schurig. And we've asked Ann to bring the Braden to light in a different way. You've seen a demonstration of working with the Braden as it was originally developed in a paper format. But what we'd like to do now is, this is an optional demonstration, so for those of you who have to scoot, but what Ann is going to show us is a demonstration of an automated Braden solution. It's called WoundRounds. It does more than just automate the Braden, but she's going to demonstrate that portion of the WoundRounds solution and how it makes the Braden scale easier to work with, but particularly makes it easier to work with the subcategories and design appropriate intervention plans. So at this point, I'd like to turn the floor over to Ann. She's also the Vice President of Clinical Operations at WoundRounds, and she's going to give us a short demo. Thanks so much, Ann Schurig.
Thanks for the great intro, Deb. So what you're seeing on your screen is how WoundRounds application handles the Braden reassessment and the display of the Braden information within our system. So here I can see that for my patient, very high risk, I can see her last 3 Braden scores, and not just her total scores and her risk level, but I can see her subcategories here listed out by each category. And we'll use a red, yellow, green dot system to visually cue the user as to how the resident or patient is scoring in a subcategory and whether we've seen a shift in that score from one assessment to the next. So even though the total score may remain static, the subcategories may shift around, and we want to make sure that we target our interventions to the subcategories that are driving that total score. To reassess a patient, it's very easy. We just click on our reassessment button, and it's going to bring back forward those subcategories that we're used to seeing. Everything's in a drop-down list format, And we even have help buttons clicked in. So if you click on a question mark, here's the description and the subcategories and how to score in each subcategory listed out for a quick refresher for you. To change a score, you just click on the drop-down arrow, and now I can see all of my scores, and I can change the category as I see appropriate. We asked 2 additional risk questions. Is there a scar over a bony prominence? Yes or no? That indicates that there's a previous wound or perhaps an incision and makes that area more vulnerable to breakdown in the future. And then we asked, does she have a non-removable dressing or device? This is defined as something akin to a splint, an AFO, a cast, Buck's traction, or perhaps even a vac dressing that's not due to be changed today. So we know that there's actual or potential skin breakdown underneath that device, but we can't assess that area just now. When I save my assessment, my score is tallied up for me, and my risk level is displayed, and I can see my subcategories and what's changed where. So I can see that in nutrition, she's moved back to red, and on moisture, she's very moist now. Additionally, I can drop down right away to my interventions pages, and I'm seeing those interventions that are currently selected. And again, I have my visual cues here in my subcategories. So wherever I see a red dot, for sure, I want to make sure I have an intervention related to that red dot in place for my resident or patient. In moisture, we have absorptive pads, but I think I want to add to that. So I'm going to go up here and amend my interventions. And now that she's in red zone, I want to make sure that I use my moisture barrier cream and I address the cause. And I want to look at my nutrition. Yeah, I think I'm doing everything I can for nutrition. So I'm going to go ahead and save. And now in a very short period of time, but in a very effective way, I've seen how I'm doing with my interventions, where I'm going with my subcategories, and I've gotten my Braden score readdressed here and updated. Additionally, I can take this to make this actionable. I can now get the system to print out a worksheet for me of those interventions that I've just selected. When this worksheet is printable, so I can share it with my team members, whether that's the physical therapy department, my CNAs or care techs, or other members on the care team, or even a family member, to show them what interventions are in place and should be being implemented and documented against for this particular patient or resident. So we take that paper form and we turn it into an actionable item so that everybody can contribute to the plan of care in an effective way. Additionally, from a facility-wide level, when we want to look at how our risk is doing overall, I can go to my facility risk summary and see in a quick pie chart how my risk is stratified. I can also see that, 20% of my residents have either overdue Bradens or no Braden at all. So when I scroll to the bottom of my list, I can look and see all the detailed information about what's up in my pie chart. This again helps make our Braden scores and our risk management more actionable rather than just a piece of paper that sits in the chart. So now I can see who needs to be reassessed, and I can see who's up to date. I can see how their Braden scores are trending. So with this simple symbol system, we can see that Rachel Ray's Braden score is trending down in a negative direction. So we want to make sure we get a look at her history and see what's changing with her. I can see up here next to Stella Tubby that her Braden score is flat. A dash means that there's been no change in score. And let's find somebody who's improving. Here we go. My remains, her Braden score is trending in a positive direction, so she's making gains, and that's just what we want to see. I can go up to the top of my list here, and I can sort my subcategories and find out how many of my patients or residents have problems with sensory issues and where all my red dots are, and then go directly to that resident or patient's page and make sure that I have the appropriate interventions in place. This is just a quick overview of how we handle things, but it's a way to make that Braden, take it out of a paper world that gets stuck in the chart and bring it forward for you to see at a moment's notice. One last note on the WoundRounds application is that not only is it web-based, but we also reside on a handheld device, so you can take that device right to the bedside and do your documentation while you're viewing that patient or resident at the bedside. So we make that information immediately available. Thanks for the opportunity to show you this, and I'm going to turn it back over to Deb.
Thanks so much, Ann. That was a great demonstration of the Braden and really helped bring it to life. One thing I've learned in working with Ann is she shares that wound care is a team sport, and by having a tool that you can use to share care plans throughout the interdisciplinary team, it really helps to get everybody playing on the team sport of wound care. What we'd like to do now is recognize we've got time for one or two questions for Ann. If you might have any questions that you might want to ask of Ann or our other speaker, Lynn, on the subject of the Braden or implementing Braden within your facility or considering an automated Braden solution for your facility. So see that one question has come up. This is a question about implementing WoundRounds. And the question is, how long does it take on average to implement WoundRounds within a typical facility? And I'll turn this over to Ann Scherg for her to answer. Ann?
This is a question that I get all the time. You know, we get very overwhelmed with the advent of electronic documentation. One of the things that we strive to do here at WoundRounds is make this a very user-friendly and actionable solution. So we've made the implementation very easy to do. Typically in a post-acute facility, anywhere between 25 and 225 beds, it'll take approximately 3 to 4 days to implement the application within the facility. And we spend a short time in the classroom learning the nuts and bolts, and then we take it out to the hallways, out to the nurses' stations, and work hands-on with our learners so that before we leave, everybody's comfortable with using the solution. In an acute care facility with a larger staff population, it may take longer than that, but typically we're looking at 3 to 4 days in your average post-acute facility.
Thank you, Ann. The next question that has come in, also from a post-acute participant, is how does the WoundRounds information cross over to MDS 3.0? I'm wondering if, Ann, you'd like to take that question.
Sure. So built into the WoundRounds application is an MDS Section M worksheet. So what we do is we extrapolate all the information on wound documentation as well as on risk and risk documentation, and we populate the worksheet. The worksheet looks exactly like your MDS submission form, and we provide all the answers that are in the system to you in one spot with the correct coding and formatting for MDS 3.0 submission.
Ann, thanks for that question. I think we're running out of time, so in the sake of time, what we will do is we've seen that some more folks have asked some questions now. We will get back to individuals via email with answers to their specific questions. So I have a couple things to go over before we wrap up today. Again, another reminder that you will be getting copies of the WoundRounds information deck that you saw today. We're going to email that out to participants again at the close of this webinar. Probably within 24 hours you should be checking your emails if you're registered for today's webinar. So you get a copy of today's deck, and you also get an opportunity to come back and ask any questions that you might have for our speakers. So also wanted to give a big thanks today for WoundRounds, who sponsored this webinar and brought these speakers and this material together to you. A big thanks to WoundRounds for continuing to do this. This is, I believe, 6th in a series of webinars that WoundRounds has brought to the participants. So what's next? I'm pleased to report that WoundRounds would like to do an additional webinar. The PUSH tool, the Pressure Ulcer Scale for Healing, is another useful tool that's used in facilities to assist in wound care. And the webinar is planned on June 28th. It's 12 noon Central Time on this next topic. If you are already a registered attendee of past WoundRounds webinars, you will receive an automatic invite for this webinar. If not, please feel free to contact WoundRounds at woundrounds.com to be added to the distribution list. So what I'd like to do is thank everyone. A special thanks to our presenters, to Lynn Ferguson, and also to Ann Scherg for bringing this valuable information together today, and also to WoundRounds for making this happen. I'm Deborah Kurtz, and I'm thanking you for participating and looking forward to seeing you next time, June 28th on the Push Tool. Thanks so much.